Button just now. Okay, so everyone, now we are in the second part of today's webinar series. So I would like to introduce you to Dr. Syahmi. He is a dedicated young lecturer, emergency physician based in HUSM. He obtained his medical degree from Penang Medical College and subsequently pursued his master in emergency medicine in USM. He's actively involved in the undergraduate and postgraduate teaching related to emergency medicine and very passionate about stroke. He is currently enrolled in the Fellowship of Ultrasound in Critical Care, in which he hopes to be able to explore further the usage of ultrasound usage in neurological emergency cases. So without further ado, I would like to invite Dr. Syahmi to proceed with his lecture of today, which is Neurological Diseases in Pregnancy and Postpartum.
All right. Assalamualaikum and good morning to everyone. So thank you to Dr. Nasrina for the kind introduction. If you notice it, I have actually added postpartum as well to the title because I think it's important to keep in mind that the physiological changes in pregnancy that brings about neurological diseases doesn't just stop at delivery. Instead, some of these changes, they persist throughout the postpartum periods, extending up to 8 weeks. So for the next 30 minutes, we will explore various aspects of neurological diseases during pregnancy and postpartum as well. So we'll look into their pathophysiology, their brief clinical descriptions, and also a symptom-based approach to diagnosis using different algorithms. And since this is quite a broad topic, I do not intend to go into each diseases management yet, but that will be done at another time. As by the end of this lecture, my aim is for everyone to have a broader perspective. Extending beyond just eclampsia as a differential diagnosis for neurological symptoms. All right, so generally speaking, acute neurological diseases that occur during pregnancy and the postpartum period can be either the manifestation of a pre-existing neurological disorder that worsens, or it can be the first manifestation of a pathology unrelated to pregnancy, or it can be an acute neurological disorder that occurs most frequently during pregnancy and the postpartum. And given the limited time that we have today, we will only focus on the third type. So what is it about the state of pregnancy that predisposes this group of patients to acute neurological diseases? Several physiological changes can occur, but we can say that the primary culprit is basically hormonal variations. Whereby during pregnancy, there will be an increase in both estrogen and progesterone levels. And an increase in estrogen, it stimulates the production of coagulation factors, which increases the risk of thromboembolism. And besides causing coagulopathy, this rise in estrogen also increases blood volume, which in turn causes hypertension. And high progesterone level, it causes the relaxation of venous wall, increasing the risk of venous insufficiency and bleeding from small arterial blood vessels. And when it comes to hormonal changes during postpartum, we can expect a fall in estrogen levels. And what it does is it leads to an increase in capillary permeability. And all these changes that I've mentioned earlier, it may independently or in combination causes vasculopathy and abnormal bioelectric activity, contributing to complications such as vasogenic or cytotoxic edema, cerebral venous thrombosis, epileptic seizure, cerebral ischemia, and also intracranial hemorrhage. And most of these neurological diseases or complication in pregnancy and postpartum, they share the similar pathway of pathophysiology. Now, this is a list of most frequent and rare neurological diseases that can occur in pregnancy and postpartum. And I will briefly describe their clinical pictures that will be used as references for the subsequent diagnostic algorithms. Right, so the first one is CVT, or it stands for cerebral venous thrombosis. So CVT is a condition where a blood clot forms in the cerebral veins or dural sinuses, leading to impaired blood drainage from the brain, potentially causing stroke-like symptoms. And the incidence peaks during the first trimester for women with underlying thrombophilia. But more than 75% of CVT cases occur during postpartum. And risk factors include cesarean section, dehydration, traumatic delivery, anemia, high concentration of homocysteine, and intracranial hypotension, which is usually related to accidental dural puncture under epidural anesthesia. And it is more prevalent in poorer countries due to higher rates of malnutrition, infection, and dehydration. So for most patients, they would present with a diffuse, progressive, and continuous headache, but 10% would have a strong piercing headache. And other symptoms include dizziness, nausea, seizures, papilloedema, focal neurodeficit, lethargy, and coma. And the specific presentation, it depends on the size and position of the dural sinuses and draining veins involved. But it also depends on the effect on intracranial pressure and any associated hemorrhages or cerebral venous infarction. And MRI remains as the first choice diagnostic investigation in the diagnosis of CVT, as CT scan, especially the plain CT scan, they usually has lower sensitivity, in which direct signs are often negative and only 30% show indirect signs. So the only direct signs of CVT that we can see on CT brain plane is hyperdense venous sinus or cerebral vein. And for example, in the CT image, we can see hyperdense straight sinus and cerebral veins. And this next image shows hyperdensity at a different location, which is at superior sagittal sinus. And this one showing hyperdensity over the right transverse sinus. But if we are able to perform a CT venogram, we should be actually looking for a filling defect in the sinus. For example, if it involves a superior sagittal sinus, then we will be able to see this special sign called empty delta sign. All right, but nonetheless, indirect signs of CVT on CT brains are more common, right? It arises from secondary changes from the venous occlusion. So there might be area of hypodensity indicating venous infection, and this area of venous infection, they might undergo hemorrhagic transformation, causing area of hyperdensity. And in the more severe cases, there might be signs of cerebral edema and midline shift. But in any case, MRI is still the best imaging. However, I'm not going to discuss more as it is not something that we routinely have as emergency room doctors. Now, the next disease that we will talk about is RCVS, which stands for reversible cerebral vasoconstriction syndrome. So it is a condition where cerebral artery, commonly MCA, vasoconstricts. It is, however, transient and reversible and has good prognosis. So the pathophysiology of RCVS is not actually completely understood, but several mechanisms and contributing factors have been proposed. So RCVS is thought to involve a transient and reversible dysregulation of cerebral vascular tone. And this dysregulation, it may lead to segmental vasoconstriction, leading to reduced blood flow and the characteristic thunderclap headaches. And this vasoconstriction, it alternates with vasodilation, right, causing fluctuations in blood flow and pressure within the cerebral arteries. And secondly, it is thought to be caused by endothelial dysfunction. And this endothelial dysfunction, it can lead to an imbalance in the production of vasodilatory and vasoconstrictive substances, right, contributing to the vasoconstriction as seen in RCVS. And hormonal and neurotransmitter imbalance also plays a role, whereby elevated levels of catecholamines, serotonin, and hormonal change in postpartum state, it can influence vascular tone and contribute to RCVS. And not to forget exogenous substances which can do the same to the vascular tone, such as vasoactive drugs, and immunosuppressive drugs. But ultimately, RCVS likely result from a combination of these different factors leading to transient and reversible cerebral vasoconstriction. So RCVS, it is characterized by abrupt onset of thunderclap headaches, and it tends to recur daily after a single thunderclap headache. And this recurrence, it actually helps us in differentiating from subarachnoid hemorrhage type of headache, which also presents with thunderclap headache. So this headache, it is often accompanied by vomiting, confusion, photophobia, and changes in visions. And epileptic seizures or focal neurological deficits may also develop, usually following the thunderclap headache. And as mentioned before, RCVS has good prognosis, whereby the symptoms, they usually regress in 2 to 3 months. And most frequent complications include subarachnoid hemorrhage, intracerebral hemorrhage, and ischemic stroke. And hemorrhagic complication, it usually precedes ischemic complications, and the disease, it usually resolves spontaneously in those patients without ischemic stroke or hemorrhagic complication. And a small percentage of patients, they may have these cervical cranial arterial dissections. And and diagnostic wise, cerebral fluid analysis or CSF analysis and brain CT, they are typically normal in terms of the finding and in the absence of bleeding or ischemia. However, CTA or MRA, they may reveal alternating dilation and arteriovascular constriction. And alternatively, we can also use TCD, transcranial Doppler ultrasound, to look for an increase in velocity due to the vasoconstriction. And TCD is also used for patients follow-up to look for resolution of the vasoconstriction. Right, moving on to the next disorder. PRES, or the full form is posterior reversible encephalopathy syndrome. It is a neurological disorder characterized by headache, seizures, encephalopathy, and visual disturbance. And pathophysiologically, it is due to reversible vasogenic edema. And the headache impress, it is typically sudden in onset and severe, and around 90% of patients experience focal and secondary GTC seizures, and the seizures are usually preceded by visual changes and headaches. And this group of patients, they also often present with altered mental status, confusion, and memory impairment. And common visual symptoms include visual hallucination, blurred vision, scotoma, diplopia. In some cases, they might have transient cortical blindness. But despite all these visual symptoms, the retina and pupils, they usually appear normal and on examination. So this vasogenic edema that is developed in PRES, it is primarily due to breakdown in the blood-brain barrier, and PRES is often precipitated by acute hypotension, which can overwhelm the cerebral vessel autoregulation. So PRES per se, it can occur in association with various conditions, including acute arterial hypertension, preeclampsia and eclampsia, renal disease, both acute and chronic kidney conditions, sepsis, and medications, particularly immunosuppressants and other vasoactive drugs. And whether it's CT or MRI, the primary finding in PRES is usually bilateral vasogenic edema, typically located in the parietal and occipital lobes. However, if we do CT, it will only show edema in 50 to 60% of patients. So ideally, patients should have an MRI performed on them when PRES is suspected. And unlike ischemic strokes of the posterior cerebral artery, PRES lesions usually they spare the medial occipital lobe and the calcarine cortex. And although PRES is usually reversible, If the underlying causes such as the hypertension and the offending drugs are not addressed, the edema can eventually lead to permanent brain damage. And additionally, PrES can occur together or independently of eclampsia, though they often overlap. And PrES and CVS, they share a few similar risk factors and may coexist. Right, so this is an example of non-contrast CT brain showing hypodensities in both occipital lobes, indicating vasogenic edema. You can see that compared to cytotoxic edema, vasogenic edema usually spares gray matter. Right, there is no loss of gray and white matter. There is no loss of gray and white matter differentiation, and the lesion is more heterogeneous compared to cytotoxic edema. Right, so next is our basically most talk about diagnosis whenever there is seizure in pregnant patient, which is eclampsia. So eclampsia is described as the onset of epileptic seizures in a pregnant woman with pre-eclampsia. Right, so these seizures are usually GTC in nature and last about 1 minute. And symptoms that may precede eclamptic seizures include persistent frontal or occipital headache, blurred vision, photophobia, epigastric pain, and altered consciousness. And bear in mind that absence of hypertension and proteinuria does not rule out eclampsia. And several mechanisms have actually been proposed to explain this eclamptic convulsion, but the key mechanism is still the same as the previous neurological disease in pregnancy, which is vasculopathy, which I have explained in detail in the earlier slide. But more specific for eclampsia, it is thought to be caused by altered response to hypertension, right? Causing arterial vasospasm, subsequent ischemia, and resulting in cytotoxic edema. And the other explanation is the occurrence of endothelial dysfunction, increasing capillary permeability and vasogenic edema. So PrES and RCVS, they usually coexist with eclampsia. It might occur, so PrES might, eclampsia might occur, and both of them might occur as the result of eclampsia or exist independently. So with regard to the timing of eclampsia, most cases, they usually occur during pregnancy and some during postpartum. And the thing with postpartum eclampsia is the patients, they tend to present late as the tendency to ignore symptoms is very high. And this is worrying as there is a higher incidence of complications such as cerebral venous thrombosis, cerebral hemorrhage, and acute cerebral ischemia. And while most women with typical eclampsia do not need brain imaging, it is indicated, it may be indicated for the purpose of ruling out its complication or alternative diagnosis, such as in the case of post-delivery eclamptic patients, in patients with focal neurological deficit, or in those with persistent visual disturbances and magnesium refractory symptoms. And similar to other diseases we talked about before, MRI is still the preferred imaging modality to look for areas of vasoconstriction, infarction, hemorrhage, vasogenic and cytotoxic edema, and rarely craniocervical arterial dissections. Okay, now let's move on to the group of less commonly occurring neurological disease in pregnancy. So I will briefly discuss each of them to ensure that we stay on schedule. So first is amniotic fluid embolism. It is a rare but severe condition that can occur during or immediately after delivery. And this condition, it involves the entry of amniotic fluid into the maternal bloodstream, triggering a complex of severe reactions. And this include inflammation, activation of the coagulation system, and collapse of the CVS and respiratory systems. Therefore, it manifests not only as neurological symptoms and signs, but also affects the cardiovascular and respiratory systems. Next is metastatic carcinoma. It is rare as well. It is a malignant tumor that arises from trophoblastic tissue. Right? It can occur after any type of pregnancy, and that would include a molar pregnancy, normal pregnancy, or miscarriage. And the neurological symptoms and signs that it presents with uh, are actually a result of metastasis to brain with the subsequent mass effect, bleeding, edema, and increase intracranial pressure. So next one is gas embolism. So it occurs when air enters the myometrium during childbirth. And this air, it passes through the venous circulations to the right ventricle, reducing cardiac output. And this air can also embolize to the brain, giving rise to neurological symptoms. And the presence of air in the retinal veins and this so-called mill wheel heart murmur would be suggestive of this diagnosis. And when it is encephalopathy in non-pregnant patient it is usually associated with alcoholism and malnutrition, but in pregnancy, it is associated with hyperemesis gravidarum, which causes thiamine deficiency. So in most patients, they will almost always present with abnormal eye movement. However, the classic triad of confusion, abnormal eye movement, gait abnormalities is not always there. And some may have metabolic acidosis, and diagnosis is by clinical response to thiamine and MRI. Right, then we have HAP syndrome, which is a complication of pre-eclampsia and eclampsia. And then we have pituitary apoplexy, which is secondary to acute infarction or bleeding of the pituitary gland. And finally, we have chorea gravidarum, which is characterized by irregular jerky movement, usually associated with various conditions, and it usually resolves spontaneously during or after childbirth. All right, so now looking back at all the different neurological diseases that we have covered briefly so far, it might be a bit confusing to know which is which, as the overlapping symptoms and signs make it challenging to do so. So of course, the best way is to go straight for advanced imaging, but that would be not feasible, especially in a resource-limited setting. So one of the option is we can actually differentiate them by the onset and progress of the overlapping symptoms and signs as shown in this table. But if that seems to be a bit superficial, we can also use some symptom-based algorithm which is more structured and systematical. So let's start by looking at the algorithm for headache in pregnancy and postpartum. Right. So the first question we ask is whether the patient has a non-history of epilepsy. Right. If the answer is yes, we then determine the timing of the seizure. Right. Specifically, we check if the seizure occurs after 20 weeks of gestation or during the puerperium period. If the seizure occurs before 20 weeks, then the next step is to adjust the anti-epileptic therapy as per the guidelines for epilepsy management in pregnancy. And this step is crucial as physiologically, a pregnancy can alter the pharmacokinetics of anti-epileptic drugs. So around pushing the need for dosage adjustment. But if the seizure did occur after 20 weeks or during the postpartum, we need to consider pre-eclampsia and eclampsia. And the same goes in those with no non-epilepsy but having high BP, peripheral edema, and proteinuria. And for those patients with confirmed eclampsia, the therapy is as per standard eclampsia therapy, but advanced imaging is required to rule out suspected complication or other causes of seizure. But if we have already ruled out both eclampsia and pre-eclampsia, then this algorithm it requires us to exclude other potential causes of seizures, such as sinus thrombosis, ischemic cerebrovascular event, infective vasculitis, so on and so forth. Right. So next we'll go through a headache diagnostic algorithm in pregnancy and postpartum. So we begin by taking a detailed history of the headache and specific clinical signs focusing on red flags. And if none of these red flags is present, then we can just control the pain and reassess for improvement. If there is no improvement, then we need to reevaluate clinically and consider neuroimaging. But if red flags are present, right, then we need to perform neuroimaging to look for press, CVT, and others. But if the neuroimaging result or finding is unremarkable, we would still need to rule out those diagnosis of interest in view of the clinical red flags, but this time using other instruments such as lumbar puncture. And we also need to think about conditions like gestosis, which is a severe form of preeclampsia, and carbon monoxide intoxication, which can present with headaches and other systemic symptoms. So these are basically two examples of the diagnostic algorithm that we can use. There are many more algorithms specific for different symptoms like focal neurodeficit, but it's a bit lengthy for me to discuss it now. So in summary, when we manage neurological diseases during pregnancy, it is crucial to understand the physiological changes that occur, such as hormonal fluctuations and CVS adaptations, which can basically influence the neurological presentations and complications. So a holistic patient assessment is also essential, both detailed histories and thorough physical examinations to identify both pregnancy-related and neurological symptoms. And using symptom-based algorithms will basically help us in systematically diagnosing and managing this condition, especially in resource-limited settings. And although we didn't get to cover the last 2 points today, tailoring our treatment plans to the special needs of pregnant patients is important because not only we have to consider the safety of the mother, but also the baby as well. So additionally, the importance of interdisciplinary collaborations among obstetrician, neurologists, and other specialists must not be underestimated, as we believe that coordinated care is the key to optimal outcomes in our patients. So I believe that is my last slide. So I open the floor to any questions if there is any.
Okay, thank you so much, Dr. Syahmi, for your wonderful talk. I think it is not right to always consider eclampsia is the only single diagnosis when we are seeing patient that comes in with a seizure or any neurological manifestation, including headache, because as you mentioned earlier, headache, it can be many other types of differential diagnosis. Of course, we do not want to miss atraumatic subarachnoid bleed, but also conditions such as sinus thrombosis, which can also be a cause of for thunderclap headache and as well as pituitary apoplexy. So if there is anyone who wants to ask Dr. Syahmi questions, I would like to open the floor now. You can type it inside the chat box, or you can just unmute yourself and ask Dr. Syahmi directly. Anyone wanna ask? Okay, Syahmi, I don't have a question for you, but I have a comment. You mentioned in your earlier slide about RCVS, right? Well, this is going to be my topic during M&M's next 2 weeks. So I find it is a very interesting topic to be discussed. We underestimated this diagnosis because RCVS was known as a quite a different name. Like for example, benign primary angiitis, postpartum angiopathy, um, and a lot more. But actually, this is the entity of RCVS, and I feel that because the difficulty about diagnosing RCVS is, even though you mentioned that MRA is sensitive enough to pick up the lesions, you will typically see a string of beads appearance, meaning you will see vasodilatation with vasoconstriction, vasodilatation, vasoconstriction.
Mhm.
But it is not always easy to be found, especially during the first week of the onset of the illness itself. But we have a score, which I will share later. Okay, so it is called RCVS2 score. By using that score, we can divide the patient whether high likelihood or not low likelihood to be diagnosed as RCVS. And if it is somewhere in between, then it is best to be referred to the neurologist, because the most prominent symptom is still thunderclap headache. So patient will claim that it's the worst headache of their life. And you might be thinking like, okay, I'm pretty sure this is a subarachnoid hemorrhage. And when you did the CT plane, you don't see anything, even if it is less than 6 hours, where you can see bleed quite sensitively being picked up from the CT brain itself. So that is pretty interesting that you brought up into this topic. And I think that since your presentation was very good, so it put a pressure on me to talk about RCVS later on. So yeah, I think we can discuss further during that time. Yeah, but it's very interesting that you brought it up, because I think RCVS, press eclampsia, they shared the similar pathophysiology in which the dysregulation of the auto regulation of the brain. So you will get to see like a lot of findings, but depending on its severity, that's how some areas they have different type of symptoms coming in as part of their presentation. So I think the picture, the diagram that you summarized the whole presentation just now, I think the one before, these two slides before, yeah, no, we go back. The two slides just before you end your lecture just now. Yeah,
Uh,
yes, that was, yes, I think it is very helpful. Yeah, I think this is a very helpful, because press usually doesn't come with headache, but RCVS, that is the about 95% of them comes with headache, and we have sinus thrombosis also can come with either seizure or with headache. So a lot of things varies with the presentation. Yeah, so anyone want to ask Dr. Syahmi any question? Um, you can unmute yourself, or you can just type inside the chat box. If you have any difficulties in basically handling patient that comes in with pregnancy, you want to do CT scan, then probably you have some difficulties over there. So Syahmi, maybe you can just enlighten us. A lot of this diagnosis, when it comes to neurological emergencies particularly, the number
mhm.
one thing that we are very interested to look for is to rule out structural lesion. It can have bleeds, they can have strokes, they can have thrombosis and what more. So how do we weigh the because when they're pregnant, we do not want to harm the fetus, and probably the patient will be a bit anxious. I mean, of course, if they are conscious, if not, they might be asking the spouse, so they are a bit concerned about the radiation that the baby might receive. So what is your advice? Because I think we have junior doctors as well with us today.
All right. I think generally we need to go back to this principle of benefits versus risk, right? So if you think the benefit of performing all these radiation emitting advanced imaging is more than the risk, I think there is no harm to perform it. Of course, you harm the fetus in a way, but if it saves the mother, then that would uh, achieve our aim of saving the mother first instead of the baby.
Yeah, I think that's pretty straightforward answer. And additionally, because when we look at the how much harmful is the radiation towards the fetus itself, if the fetus is not in the early teratogenic phase, I think it's not much to be worried of, because mostly the um, major organ has been formed. And when we look at the dose itself, so CT scan, I think it's about 0.5 millisievert. For you to get acute radiation syndrome, you need 1 sievert. So that's like very much lower. And we're just scanning the head. So it's until probably the neck, and they will shield the baby itself. So I think for those who might find it a bit difficult to counsel the family members or the husband or the patient themselves, maybe you can explain that actually the risk is almost but we cannot say for absolute it's zero, because you also have background radiation, but at least you can say that it's very, very, very much low to affect the baby. And as what you said, the whatever that happens to the mother will also endanger the fetus as well. So we need to save the mother first, and based on that principle, yeah, it's always a benefit. Is much more, it outweigh the harm. All right. Any one last question before we end the session today? Okay, if there is none, thank you so much, Dr. Syahmi, for your time, sharing with us this exciting topic, and I hope that it will be an eye-opener for most of us. And before we end, I think it is a tradition for the for all of us to have a group photo. So perhaps you can, Syahmi, maybe we can stop sharing. We can take photos.